All right, good morning, everyone. Welcome to our regular cardiology conference. Before we get started, we have our usual feature of highlighting a study, and this one actually I'm involved in. It's sponsored from Nanocor, and it's for patients with non-ischemic cardiomyopathy. It's myself and Kasha are working on this study sponsored by AskBio, and basically this is a gene therapy study where we're injecting the gene for this protein called I1C, which is involved in SERCA2A and calcium handling in patients with cardiomyopathy. And it's given by an intracoronary infusion, so it's very simple and straightforward. It's not an intramyocardial injection like other studies we've been involved in. So basically the criteria is kind of broad. We just need you to have patients in New York Heart Association class 3 with an EF of 30% or less, and just have a chronic non-ischemic cardiomyopathy of, and they really don't stipulate what type of non-ischemic cardiomyopathy, so I think we'll take all comers. So, and then the exclusions are, obviously, if they have an ischemic cardiomyopathy, they're not a non-ischemic patient. So, and then renal failure would be the other one. So if you have any questions, feel free to reach out to myself or Kasha or Jake or Carrie or Jane Fox on the study. So thanks.
Good morning, everyone. David Pearl. I have the distinct pleasure today to introduce Paige Skelton, our speaker. Paige is a clinical pharmacist here with Abbott Northwestern Hospital and Minneapolis Heart Institute, who many of you may know. She's the kind of pharmacist we love because she works with our advanced heart failure group and our sickest of our sick patients. Paige trained at the University of Minnesota and then interned with us here at Abbott Northwestern, and her specialty is obviously in the world of cardiovascular medicine. We've asked Paige to give us an update on where we're at with all the supplements that intermix with our medications, and there's always something new on the horizon. And of course, in the last few years, we've been inundated with THC, CBD, and their effects also with cardiovascular medicine. So we thought that it would be fascinating to have her give us an update today. I also learned that Paige and I share a passion for Stella. Mine happens to be a beer, hers happens to be a horse. So, without further ado, Paige Skelton. Thanks, Paige.
I do like Stella beer, too. Not why her name is Stella. All right. Good morning, everyone, and thank you for tuning in on this early Monday morning at 7 a.m. As Dr. Hurl mentioned, I was asked to come present on updates on supplements, and I kind of pulled in the THC CBD part as well, and kind of how that all interacts with cardiac medications. So many of you are probably sitting there saying, yes, I've definitely met with a patient in clinic, or yes, I've had a patient in the hospital that says, I use this this herbal supplement, and you probably go over to the computer and you try and type it in. A, you can't even find it in the computer. B, you say, what dose are you on? They say, oh, I don't know, my bottle's at home. So this topic often can be a little bit challenging with patients, and this is where I like the world of technology and asking patients to take a picture and send it in to us. But we'll just kind of talk through some of these different supplements and interactions with THC and CBD, and really what we need to know in terms of cardiac medications. So I have no disclosures. The objectives that we'll kind of talk through today are how you guys can locate resources on the AKN to evaluate herbal supplements. So as you can imagine, I'm only going to touch on a handful of them today, which is not all supplements that are available. So kind of educating you guys on where you can find some of this information too when you come across this with your patients. Secondly, we'll talk about Abbott Northwestern Hospital's non-essential medication policy. So this might be a policy that some of you aren't even aware of that our pharmacists utilize that we'll talk a little bit more about. Then we'll go into talking about some various herbal supplements and talking about their safety with common cardiovascular medications. And then lastly, we'll summarize some common drug interactions with THC and CBD and what we need to know as clinicians if we have patients that are utilizing these products. So just a little bit of background. So roughly 40 to 60% of adults in the United States with chronic diseases use dietary supplements. And among those patients taking prescription medications, roughly a fourth of them also use herbal supplements. I think this is probably something we don't maybe think that it's 1 in 4 of our patients because we might just not even know that they're taking them. This is where I really encourage, whether it's your clinic assistants in clinic that are obtaining medication histories, whether it's you, the clinician yourself, talking with the patient, whether you're a pharmacist doing medication histories in the hospital. A really important question we always have to remember is not only what prescription medications you're taking, but do you take any over-the-counter products and do you take any herbal supplements? As the statistic shows, it's a lot more common than I think we probably truly see, and that's because we just don't have all the information. So what exactly is a herbal supplement? So it's a supplement containing whole plant or plant extracts that are consumed as powder, capsule, tablet, or liquid formulations. So first I'll kind of transition into where we can utilize probably I think our best resource here at Allina, and that's natural medicines. Has anyone in the audience here used this resource before or know how to get to this resource? If you're like me, anything on the AKN is a little bit of a mystery trying to find. So I wanted to make sure I could show you guys here in this presentation for your reference. So from the main AKN page, if you click on patient care up at the top, and then click on library services in the bottom left-hand side of the screen, that will bring you to this page here, where then you can click into research tools. And then from there, you click on natural medicines, which then there's a little link below, which brings you to the website. So this is what the natural medicines website looks like. And at the top, you just type in whichever herbal supplement or product that your patient has. So from there, it essentially brings you into a page that looks a lot like Micromedics in a sense, where on the left-hand side, it'll say common uses, adverse effects, drug interactions, things like that that you can really look into. This is also a good resource too. If there's going to be data out there, it's likely going to be sourced in natural medicines. So this is always what I kind of go to as my first reference whenever I have a provider or someone else asking, hey, can you look and see if this supplement is safe for this patient to use? So next we'll kind of transition into talking about the non-essential medication policy. So this is RX 489 in the pharmacy world. We're like type A OCD and we call everything by its RX number. So if you ever hear us talking about RX 489, that's the non-essential medication policy. So the purpose of this policy is to provide guidance to healthcare providers about prescribing, dispensing, and administering non-formulary, complementary, and non-essential therapies. So just some little definitions here. So non-formulary is a medication that's not on Allina Health's medication formulary. So we do have a Allina-wide formulary that goes through Allina Clinical and then also our individual hospitals, pharmacy and therapeutics or P&T meetings. Complementary products are products designed for systemic or topical use that have not been approved by the FDA and are not otherwise classified as pharmaceuticals. So an example of this would be herbal supplements, what we'll be talking about here today. And then non-essential is a product that may or may not have FDA approval and is not required for the clinical care of the patient during hospitalization and will not cause harm to the patient during their hospital stay if that product is discontinued. So kind of why this this policy was put into place was that, as you can imagine, with patients coming in on medications as well as some of these complementary or non-essential medications, often these are things that we don't stock in our inpatient pharmacy. And so when a pharmacist is doing the medication history and helping reconcile that medication list, there might be things that we say, hey, this isn't something we have, but it's non-essential to the patient and okay if they hold while they're here in the hospital. So per policy, the pharmacist is able to reject that order. And so this kind of flow diagram in the policy kind of walks through it, and basically where you can see the outlined red box on the left-hand side, you can see if there is a non-formulary medication ordered by a provider, if the medication is considered non-essential and not ordered as DAW or dispense as written, the pharmacist does have the ability to reject that order per policy from this RX 489. And so basically this is just a conversation that we have with the providers. If there is something that would cause a significant interaction, if we were to hold it within the hospital stay, that would be a conversation we would be having with you guys. Or if it's something we do carry in the hospital, maybe it's just a different form of vitamin D or something along those lines, then again, we'd contact you guys to make sure it's okay that we're switching kind of a formulation as well. So hopefully it's still not too early for a Monday morning to scare you guys away with a little pharmacology review. This little cartoon actually reminds me dearly of my pharmacology professor that has since retired, but I had to throw him in here. So there are over 50 cytochrome P450 enzymes. And so with that being said, there's 6 of those enzymes that really metabolize about 90% of the medications we use today. So our SIP1A2, 2C9, 2C19, 2D6, 3A4, and 3A5 are those 6 enzymes that really kind of make up about 90% of the drug's metabolism that we use. So you'll see, and you're probably thinking in your head maybe of a couple medications that you know of that go through some of those certain metabolic pathways. So just some verbiage here. So a substrate, our drugs are substances metabolized by cytochrome enzymes. An inducer is a medication that increases the rate of drug metabolism. So with inducers, it's important to know that these can reduce concentrations of drugs if they're going through the same metabolic pathway. So this could potentially lead to subtherapeutic drug levels or treatment failure. On the flip side, we have inhibitors, which decreases the rate of metabolism. So therefore, you can actually result with increased concentrations of these medications. And then just to make it a little bit confusing, we also have to remember that we do have some medications that are prodrugs. So one that probably comes to your guys' mind in the cardiology world is clopidogrel or Plavix. So in terms of inhibitors with clopidogrel, you actually might see reduced effects of clopidogrel since that medication requires conversion to its active metabolite. So on top of what we'll kind of talk about with some of these SIP enzymes and the herbal supplements, we also kind of have to understand how they interact with the specific medications. So these next 2 slides I just kind of wanted to include for you guys to reference back. If further in the presentation, we'll be talking about certain herbal supplements not affecting certain enzymes. And so this is just kind of a reference point. So you'll see here that with the table, I tried to highlight in bold any cardiac medications in red, just to kind of draw your attention there. I did want to include some other medications that we commonly see. There's some things like antidepressants, antipsychotics, allopurinol. We see quite a fair amount of gout, transplant medications, cyclosporin, tacrolimus, things of that nature. So this is kind of just a reference point if you're looking back at this later to see which medications go through these pathways. And then similarly for the SIP inducers, same thing. So there's not as many medications that are inducers, but the one to really highlight here, even though it's not a cardiac medication, is rifampin. We see quite a bit of rifampin use, especially with staph infections, because our good old staph likes to stick to foreign things in our body, like our valves, our LVADs, our whatever it might be, pacemaker leads. So unfortunately, we see rifampin, which is a whole nother can of worms with drug interactions. All right, so we'll switch into talking about the herbal supplements. I'll just check where I'm at with time. So where do we begin? No. So I picked the 16 supplements to talk about. I kind of went off of what is known as the most commonly used herbal supplements. So again, there's obviously a lot more than 16 herbal supplements. So if at the end of the presentation you're thinking, oh, I commonly see this or this herbal supplement, feel free to shoot me an email or in basket message me in Epic. I'm happy to kind of talk through some of the other supplements as well. So then the first one we'll start with is black cohosh. So just to kind of orient you to how each of these slides will be for each supplement, I put the scientific name for completeness. I'll be honest, I'm not going to try and pronounce them because I'll probably say them incorrectly. I included uses, side effects, and then drug interactions. So again, tried to highlight in bold and red the cardiac medications for you to keep an eye on. And then anything that's bolded in purple at the end is kind of the take-home point if you were to read one line on this slide. So again, with black cohosh, many of you probably have seen this mostly used with our female patients, as there is some evidence in menopause. There's insufficient evidence in premenstrual syndrome or PMS, infertility, and osteoporosis. You likely have heard about black cohosh because of its estrogen-like activity, so that's why we see it used in the female population. Generally, in terms of side effects, they're very mild. Stomach upset, cramping, headache, rash, weight gain, and there is the potential for liver damage. So that is one thing to keep in mind if you do have female patients using black cohosh that do have concerns for liver damage or elevated LFTs or things of that nature. In terms of drug interactions, the drug interactions with this one is actually not through a SIP or cytochrome P450 pathway. It's actually through the OAT P2B1 pathway. So there's actually reduced effectiveness with amiodarone, fexofenadine, glyburide, and many statin medications. All in all, there's no major clinical drug interactions, but it is something to keep in mind if you do have a patient on amiodarone, for example, or statin medications, that you don't feel like you're getting the full bang for your buck with those medications if they're on black cohosh. This will kind of be where I'll always go back to, it's kind of a conversation with the patient. Is the black cohosh really helping them versus the benefit they could be getting from amiodarone or their statin medication? So it's always kind of looking at that risk versus benefit profile. The next enzyme is Coenzyme Q10. This is one many of you have probably seen and have many patients on this medication, or herbal supplement, I should say. It's used for coenzyme Q10 deficiency and then also mitochondrial myopathies. So this is our classic patient on a statin medication that has the muscle aches and pains, and we really want to keep them on the statin to help reduce that cardiovascular risk. And so oftentimes we reach for coenzyme Q10 to see if this can potentially help. Side effects with this one are generally pretty mild. There's potentially some appetite suppression, nausea, vomiting, diarrhea, and heartburn. If patients are taking over 100 milligrams per day of coenzyme Q10, it's best if you split it into more than one dose, and that often can help alleviate the side effects. In terms of drug interactions, there are potential additive effects with antihypertensives, so resulting in potentially some hypotension, and then also reduced anticoagulant effects of warfarin. So again, this one is, there's no major clinical drug interactions, but if you have a patient that's on coenzyme Q10 as well as warfarin, and they're having labile INRs or difficulty managing their INRs, this would be one thing to maybe look at. I always say with anything, but especially herbal supplements, if a patient's going to take them, they need to take them daily, just like they would their medication. And I know that, sounds silly, but if they're kind of taking their coenzyme Q10 one day and not the next day, that can maybe contribute to some of those fluctuations with their INR. Next, we have Cranberry. So the best evidence for the use of cranberry is in preventing urinary tract infections. I always try and remind people that this is taking a true cranberry supplement and not cranberry juice. I think we get a lot of patients that want to just drink cranberry juice when that juice is really filled with a lot of sugar, and then they're really just excreting more sugar in their urine and making their urine more sugary. So that isn't necessarily helpful versus taking a true cranberry supplement. There's insufficient evidence for the use with benign prostatic hyperplasia or BPH or kidney stones. But again, the best evidence for use is preventing UTIs in those high-risk patients or history of recurrent UTIs. The U.S. Food and Drug Administration has approved a qualified health claim for the use and prevention of UTIs with cranberry, so that is kind of good to know too, that it isn't kind of just, I think sometimes people think that that isn't true, that you can use cranberry. In terms of side effects, again, pretty well tolerated, dyspepsia and then diarrhea at very high doses. In terms of drug interactions, there is the potential to increase warfarin concentrations, therefore increasing the INR. But 2 human clinical trials did show no significant effect on either outcome, so no significant effect on increasing the concentration of warfarin or increasing INR. So really, when it comes to me thinking about talking with my LVAD patients, if they read the warfarin book that they get in the hospital, cranberry's listed in there. If they say they like to have a glass of cranberry juice in the morning with breakfast, I'm really not worried about it. I think there's a lot of other things that they can do to alter their INR before cranberry is the large issue. So again, no major clinical drug interactions here. Next, we have curcumin. So curcumin can be used for allergic rhinitis, depression, hyperlipidemia, non-alcoholic fatty liver disease, osteoarthritis, and pruritus. In terms of side effects, usually it's pretty well tolerated. Again, there's potential for stomach upset, including flatulence, nausea, vomiting, diarrhea, vertigo, and liver damage. And there has been reports with the liver damage of non-infectious hepatitis, cholestasis, and hepatocellular injury. So again, just something to kind of keep in the back of your mind if you do have a patient on curcumin that also has liver concerns. In terms of drug interactions, curcumin actually induces cytochrome P1A2, which could cause decreased levels of many antidepressants and antipsychotics. So really, human clinical trials so far have demonstrated no effect on CYP2C9, 3A4, or the UGT pathway. So with this, as of right now, we don't have any major clinical drug concerns or drug interactions, but do have some data to show certain pathways like 2C9, 3A4, and UGT are likely safe. And so you'll kind of see this as a theme throughout the presentation, that there are some enzymes that have been specifically studied where we know are likely safe. And then for the others, it's hard to draw that hard conclusion on without the data there. Next, we have Echinacea. This is where you commonly probably see patients use this if they're not feeling well, or maybe they have a common cold. In terms of side effects, stomach upset again, nausea, vomiting, diarrhea, heartburn, and rashes. In terms of drug interactions, there's caution when used with antipsychotics and antidepressants metabolized by 1A2. 1A2 is a very common enzyme with antipsychotics and antidepressants. And then also with CYP3A4. There is the potential for increased clearance of warfarin, though it's not clinically significant, because when we think of how warfarin is metabolized, it's primarily metabolized by CYP2C9, and that's the S-warfarin, or the more potent metabolite of warfarin, whereas our warfarin, or the less potent metabolite of warfarin, is metabolized by 3A4, for example, and 1A2 actually. So really, in terms of the warfarin interaction, likely not clinically significant. And again, we do have human clinical trials showing no inhibitory or inductive effects on 2D6, 2C9, or P glycoproteins. Next, we have garlic. I feel like this is a common one that I often have conversations with patients in clinic. Garlic is possibly affected for atherosclerosis, diabetes, hyperlipidemia, hypertension, non-alcoholic fatty liver disease. Side effects include abdominal pain, body odor, flatulence, poor smelling breath, and nausea. In terms of drug interactions, there actually are some significant drug interactions to keep in mind with garlic. So we do see decreased concentrations of drugs transported by P glycoprotein. So these drugs include colchicine, digoxin, doxorubicin, quinidine, rosuvastatin, tacrolimus, and verapamil. So really the general recommendation is to avoid concomitant use of those medications with garlic. But if you're kind of put in a corner where you're stuck with those medications, let's say it's tacrolimus, for example, in our transplant patients, we're monitoring levels, or if it is a medication, you can monitor levels or labs. That's definitely recommended in this case. Human clinical trials have shown no effects on CYP1A2, 2D6, or 3A4. So medications metabolized through those pathways are likely safe. Next, we have ginkgo. This is another one that maybe you guys have heard of before with your patients. It's possibly effective when used for anxiety, dementia, premenstrual syndrome, schizophrenia, stroke, tardive dyskinesia, and vertigo. I probably should have put at the beginning here too, a lot of these uses aren't, probably as scientifically studied as one might think. And so that could be a whole nother presentation in itself on the actual data behind the uses of some of these herbal supplements for these specific, if you want to say, indications or uses. Side effects include dizziness, some GI symptoms, and headache, but generally pretty well tolerated. In terms of drug interactions, caution with antiplatelets and anticoagulant medications, as garlic might inhibit platelet aggregation. So therefore, you'll have that increased risk of bleeding. And that does hold true with warfarin. With that being said, the data out there in terms of those drug interactions or potential drug interactions with warfarin hasn't really been solidified because there was a meta-analysis of 18 trials that failed to demonstrate that ginkgo actually increased bleeding risk or had significant effects on hematologic parameters. But then there is a single case series out of one medical center that did show that, my phone's talking, that did show that there was an increased risk of bleeding when patients were using both ginkgo and warfarin. So basically kind of how I go about this is if I do have a patient on warfarin that really would like to take ginkgo, I just, same thing, encourage them to, if you're going to use a supplement, use it on a daily basis. Think of it like how we talk about vitamin K in our leafy greens and green vegetables. If they're consistent with their ginkgo use, we can monitor their INR and adjust their warfarin accordingly. So we do have trials showing no significant effects on 1A2, 2C9, 2C19, 2D6, 2E1, and 3A4. So overall, no major clinical drug interactions to be concerned about. Next, we'll talk about ginseng. So I actually have 2 slides on ginseng. How many people knew that there's an American ginseng and an Asian ginseng? Truthfully, I didn't know that until I was doing this presentation either. But they're actually very different in terms of their drug interactions. So again, this would be if you have a patient that says they're using ginseng, asking kind of additional questions to see specifically which type of ginseng they're using would be a very good start because their pharmacologic profiles are different between American ginseng and Asian ginseng. So for American ginseng, It's possibly effective when used for diabetes and respiratory tract infections. Again, generally well tolerated. Some side effects might include headache, nervousness, trouble sleeping, and stomach complaints. In terms of drug interactions, there's potentially decreased effectiveness with warfarin, enhanced blood glucose lowering effects with anti-diabetics, so caution with the potential for hypoglycemia. And then also potentially decreased effectiveness of immunosuppressants. There was one trial of American ginseng in healthy volunteers taking warfarin that showed that ginseng on average lowered their INR by 0.2. So again, this is one of those things, if you have a patient taking ginseng and they're on warfarin, if they're taking it daily, really we can account for that drug interaction with close monitoring and let the patient know that if they were to stop taking ginseng, we just want to be monitoring their INR more closely. So on the other hand, we have Asian ginseng. So this is potentially used for cognitive function, erectile dysfunction, influenza, multiple sclerosis-related fatigue, and then increasing sexual arousal. Potential side effects include insomnia. In terms of drug interactions, there's increased caution when used with anticoagulants and antiplatelets, as there is the potential for increased bleeding risk. And then also with any anti-diabetic medications, as ginseng can also lower blood glucose levels as well, so caution for hypoglycemia. Same thing with insulin. Furosemide, there actually are some reports of Asian ginseng and furosemide resistance, which I thought was quite interesting. Immunosuppressants, Asian ginseng actually works to stimulate your immune system, so there's potential theory that they can kind of work against each other. And then also potential QT prolonging medications, as Asian ginseng can potentiate the prolongation of the QT interval. So just some things to keep in mind there. We do have data to show no effects on CYP1A2, 2D6, 2E1, and P glycoproteins. So in general, it's recommended to actually avoid Asian ginseng if patients are using concomitant medications, just because of the wide variety of potential interactions. So this would be one if you know a patient is using Asian ginseng, really looking at the risk versus benefit of why they're using it, and if there are any potential switches you could make with their medications, looking at that route as well. Goldenseal. So this is one I haven't truthfully seen or heard of anyone using in practice, but it is one that I would say is up there with, we'll talk about later, St. Johns Wort. This one has quite a few interactions. So hopefully if you remember Goldenseal and think to look further, you'll probably dig up some information. So there's some evidence for use in common cold, upper respiratory tract infections, nasal congestion, allergic rhinitis, gastritis, peptic ulcers, colitis, diarrhea, urinary tract infections, and menorrhagia. Some side effects include stomach upset, rash, bitter taste, and headaches. In terms of drug interactions, there's quite a bit, like I mentioned. So Goldenseal is shown to inhibit CYP2D6 and 3A4, which those two specific enzymes alone are responsible for more than 1/2 of our currently used medications. So specifically, we can see additional blood pressure lowering effects with amlodipine. For some patients, that might be a good thing. For some patients, not a good thing. Increased risk of bleeding with antiplatelets and anticoagulants. Increased risk of hypoglycemia with antidiabetics. It can increase cyclosporin and tacrolimus levels. So again, those are things we can keep an eye on with monitoring of levels. Increased digoxin levels. We know how that can get hairy quickly with that narrow therapeutic index of digoxin. And also decreased effectiveness of losartan. So really in general, with Goldenseal, if you have a patient on that, again, if you think to just look through their medications and look for any potential interactions, but the general recommendation is to avoid the use of Goldenseal with any pharmacy or pharmaceutical medications. So next we have green tea extract. So green tea extract is used for cognitive performance, mental alertness, stomach disorders, headaches, depression, and obesity. There is a FDA-approved qualified health claim for the use in prevention of prostate and breast cancer. Generally, green tea extract is very well tolerated when consumed in beverages, which I think is what most patients are going to be asking about. Can I have a cup of green tea? And really, that's where likely when patients are just drinking green tea, unless they're drinking like 8 to 16 cups a day or excessive amounts of green tea, there's not going to be any significant drug interactions. There is the potential for hepatotoxicity, and there actually is a USP stamp that has to be included with green tea supplements stating this liver toxicity warning. So again, just something to kind of keep an eye on. Otherwise, again, generally well tolerated, potentially some GI side effects. In terms of drug interactions, green tea extract can increase concentrations of simvastatin. It can reduce plasma levels of atorvastatin or rosuvastatin. It can increase your bleeding risk with anticoagulants and antiplatelets. And then it can also reduce the concentration of nadolol. In terms of warfarin and green tea extract, this is another one in our Alina patient book that we give on warfarin education. Green tea is included in there. One thing I always just kind of ask is how much green tea do you typically drink? Is it something you do on occasion, or is it a daily part of your routine? When you look at green tea, most green teas contain about 7 to 10 micrograms of vitamin K per serving. So, and again, unless you're really drinking excessive amounts, they state at least 8 to 16 glasses, that's where you would really need to like have that much green tea to cause a clinically significant interaction with warfarin. So it kind of makes me think about patients I talk to that take the lettuce off of their burger when they eat a burger because they don't want the lettuce to interact with their warfarin, their one piece of lettuce. So likely in terms of the anticoagulant and antiplatelet parts, I'm really not too concerned. But we do want to avoid use with the oat 1A1, 1A2, and P glycoprotein drugs. Next, we have Kava Kava. This is possibly effective for anxiety. Side effects include stomach upset, headache, dizziness, drowsiness, enlarged pupils, dry mouth, and again, hepatotoxicity. Hepatotoxicity is one thing I did not think would be so prevalent with some of these herbal supplements, but it is one thing to kind of keep in mind, again, if you do have patients that do have liver concerns. Specifically with Kava Kava, there's over 100 cases of hepatotoxicity noted worldwide with use of Kava Kava. But really, this herbal supplement is primarily used with general anxiety disorder. In terms of drug interactions, we can see increased drowsiness with CNS depressants and increased levels of anesthetics and acetaminophen. So an important thing to remember with this, if you see that you have a patient on Kava Kava, if they're coming in for a procedure that's going to require general anesthesia, it's recommended that they stop this supplement 5 days prior to their procedure. Again, just because that additional CNS depression when used with general anesthetics. So there's no clinical studies showing effect on 1E2, 2D6, 3A4, and P glycoproteins. Kava Kava is shown to inhibit CYP3A4 and then there's also in vitro data suggesting inhibition of CYP2C9 and 2C19. Next, we have milk thistle. This is primarily used possibly for possible effectiveness with diabetes. There's insufficient evidence for alcohol-related liver disease, allergic rhinitis, benign prostatic hyperplasia, and then hypercholesterolemia. In terms of side effects, generally well tolerated, potentially some abdominal bloating, dyspepsia, and nausea. With drug interactions, we can see reduced losartan metabolism and increases in warfarin concentration, phenytoin concentration, and diazepam concentrations. Again, so we have clinical trials showing no inhibitory or inductive effects on CYP3A4, 2D6, 2E1, 3A4, and P glycoproteins. No major clinical drug interactions with milk thistle. And then we have saw palmetto. So this is probably one you guys have also seen a decent amount of with your patients. So the best evidence for saw palmetto is actually in reducing complications of transurethral resection of the prostate. And then it's listed as possibly ineffective for BPH, but I think that's where we probably see the most of our patients using saw palmetto. It's thought to have anti-androgenic, anti-proliferative, and anti-inflammatory effects. Generally well tolerated, potentially some stomach upset, dizziness, and headaches. Drug interactions include potentially prolonging bleeding time with anticoagulants and antiplatelets. But we do have human clinical trials showing no inhibitory and no inductive effects on CYP3A2, 2D6, 2E1, and 3A4. So again, this one is generally pretty well tolerated in terms of drug interactions. There's no major clinical drug interactions. Coming up towards the end here of least of the supplements, we have St. Johns Wort. This is probably one that a lot of us remember hearing about in school or hearing about from patients. And so this is likely effective when used for depression. See a fair amount of people using St. Johns Wort still today. And then it's also possibly effective for menopausal symptoms. Side effects, again, generally well tolerated, potentially stomach discomfort, dizziness, dry mouth, fatigue, headache, and restlessness. Drug interactions include potentially decreasing the effectiveness of cyclosporin, tacrolimus, warfarin, protease inhibitors, theophylline, digoxin, venlafaxine, and oral contraceptives. There's many human studies showing St. Johns Wort is a potent inducer of 3A4 and also P glycoproteins, which again kind of encompasses a lot of medications we use today. So that's why you'll see, in general, we just recommend patients do not use St. Johns Wort with other prescription medications. And if they're very adamant about it, this would definitely be one to do an in-depth review of their medication list. And then I believe this is the last supplement I have, Valerian. And so Valerian is possibly effective for insomnia. Side effects include dizziness, drowsiness, and mental slowness. One thing to note with Valerian, if you do have patients taking it, is if they would like to come off of Valerian, you actually should recommend tapering down the dose to avoid withdrawal symptoms. And so withdrawal symptoms might include tachycardia, anxiety, irritability, and insomnia. In terms of drug interactions, there's potential additive sedative effects with CNS depressants, alprazolam, and alcohol. We do have human clinical trials showing no inhibitory or inductive effects on 1A2, 2D6, 2E1, and 3A4. So overall, Valerian is pretty safe, no major clinical drug interactions. So that is what I kind of had for the herbal supplement piece. So again, I know that's not all herbal supplements that are available. So if there's additional herbal supplements that have came to your minds throughout the presentation, feel free to shoot me an email or in-basket me if you have specific questions about other ones. So now we'll just transition into THC and CBD. And so check where I'm at here with time here. Okay, so this is just a map to kind of show you guys where we're at within the United States on the different laws and regulations with THC and CBD throughout the country. And so you can see in Minnesota, we have medical marijuana, so it is medicinal, and it's also decriminalized. You can see on the West Coast, predominantly it's legalized across the board. So kind of throughout the states, it's different from state to state. Specifically here in Minnesota, This is a list of qualifying conditions that you could get a prescription for medicinal marijuana. So I won't go through these specifically, but I think they're just good to note. Truthfully, I think when I'm talking about this with patients in clinic, it's rarely that they have a prescription for medicinal marijuana. It's usually for recreational use. So this is important to note too, though. So just a little bit of background. So THC and CBD are pharmacologically active cannabinoids in marijuana. THC is metabolized by SIP3A4 and 2C9. So there's potential increases in THC concentrations when used with SIP3A4 and SIP2C9 inhibitors. So this is important because potentially patients could be taking medications that actually increase the effects of THC, increasing those psychoactive effects. CBD is metabolized by SIP3A4. So therefore, there's potential increases in CBD concentrations with 3A4 and 2C19 inhibitors. So again, same thing where we're potentially concerned about increases in the psychoactive effects with certain medications. So kind of a quick 5 things to know. Cannabinoid levels can be increased by other medications. So that's kind of what we just referenced with some of those CYP enzymes. Cannabinoids can affect levels of other drugs. So we might see either higher levels of other drugs or lower levels of other drugs. So potential treatment toxicities or subtherapeutic effects. Smoking marijuana can increase clearance of some drugs. So again, this could be important to note as we might not have as high of levels as we would think, so leading to potentially treatment failures. There's additive effects that can occur with other drugs. So with sympathomimetics, we can see tachycardia and hypertension. With CNS depressants like alcohol or opioids, for example, we can see drowsiness and ataxia. And then with anticholinergics, we can see tachycardia and confusion. So kind of where we'll wrap up this presentation is through some tables to kind of highlight some potential red flag interactions. And so just to kind of orient you to the tables, you'll see that I've broken it up into THC and CBD columns, and then the rows will be different cytochrome enzymes, and if they're inhibitors or inducers. So same thing I highlighted in bold and used red text for the cardiac specific medications. So we'll start with the SIP3A4 inhibitors. So important ones to note here, diltiazem, verapamil, and amiodarone. So with this, we have seen increased, or ketoconazole has increased THC concentrations nearly 2-fold. So they've kind of extrapolated that similar interactions are possible with other 3A4 inhibitors. So this would result in enhanced THC psychoactive effects. So just kind of, again, similar with the herbal supplements, we might not have like explicit data on each individual drug, but knowing their metabolic pathways, we can draw conclusions about potential interactions. Same thing holds true for CBD. So in this instance with the 3 and 4 inhibitors, THC and CBD are both the same, potential increased psychoactive effects. In terms of the 3A4 inducers, rifampin is shown to decrease THC concentrations roughly 20%. So there's the potential for similar interactions with other 3A4 inducers. The clinical significance of this is unclear. In terms of CBD and 3A4 inducers, rifampin decreased CBD concentrations by roughly 60%, so a more significant effect. Combined use may decrease effectiveness when used with seizure disorders. So if you look over to the left, phenytoin and phenobarbital are some common 3A4 inducers. So this could be a clinically significant interaction if you did have a patient with a seizure history. All right. And then we have CYP3A4 substrates. So some common ones here are PDE5 inhibitors. So whether you're using it for erectile dysfunction or if it's sildenafil for RV failure or pulmonary arterial hypertension. diltiazem, verapamil, cyclosporin, tacrolimus, sirolimus, simvastatin, atorvastatin, so quite a few cardiac medications. So with THC and 3A4 substrates, there's no effect of THC on 3A4 substrates, so that one makes that one simple. In terms of CBD, CBD increases tacrolimus concentrations roughly threefold. So if you do have a patient on tacrolimus that needs to be on tacrolimus, close monitoring of their tacrolimus levels would be recommended. And so then they kind of extrapolate again that other 3A4 substrates can have possible similar interactions with CBD. So again, really just monitor for adverse side effects, and if you have a medication that you can monitor levels, make sure you're doing that as well. In terms of 2C9 inhibitors, we have sulfamethoxazole, so common ingredient in Bactrim, amiodarone, metronidazole, fluconazole, voriconazole, and valproic acid. So THC, or these medications may increase THC levels, again, thus enhancing those psychoactive effects. And then there's no known concerns with CBD with 2C9 inhibitors. Then we have 2C9 inducers. So rifampin falls into this category. So 2C9 inducers may decrease THC levels, attenuating psychoactive effects. Then we have 2C9 substrates, so warfarin and rosuvastatin fall into this category. THC may increase levels of medications like warfarin and rosuvastatin. Therefore, we recommend that you monitor for adverse reactions and dose reductions as needed. In terms of warfarin, there are cases of increased INR and bleeding with smoked marijuana. This is one thing I will say I have seen clinically firsthand. We do have patients that use marijuana recreationally that I truthfully think of this almost as like a vitamin K issue or like a leafy greens, green vegetables issue. And so in patients that are kind of consistent daily marijuana smokers, we tend to not see as big of alterations in their INR. And if we do, it's kind of initially, whereas it's where we see more concerns is with kind of the periodic smokers that only smoke once in a while, and we've seen INRs 5, 8 really increase. And so this is something I always just kind of, similar with herbal supplements, you know, I try and ask some of these questions now that, you know, when we're talking about warfarin, it's not just, have you changed any medications? Has your diet changed? Have you had any alcoholic beverage? I also throw in, you know, any use of recreational marijuana or medicinal marijuana. So you'd be quite surprised how many people will actually admit to that, which I'm happy because we're trying to help the patient and keep the patient safe. So oftentimes just kind of explaining this interaction, the patient kind of makes the decision of, this probably isn't the safest thing for me. And so I like to at least be able to have that conversation with them. With CBD, same thing, warfarin and rosuvastatin, CBD may increase their levels. So again, keeping an eye out for adverse effects like bleeding with warfarin. In terms of 2C19 inhibitors, no effects anticipated, so we're okay there. With 2C9 inducers, no effects with THC. And then in terms of CBD, rifampin can decrease the CBD roughly 60%. And then for 2C19 substrates, no effects anticipated with THC. But in terms of CBD, CBD increases levels of clobazam 6-fold. So that's benzodiazepine. So again, they kind of extrapolate that similar interactions may occur with other 2C19 substrates. So it's important to monitor for toxicities. And then one common medication that we see a lot of is clopidogrel or Plavix, and CBD may compromise the antiplatelet activity of clopidogrel. So again, this is something I think that's important to have this conversation with patients, especially after fresh stents or some of the procedures that we do here. clopidogrel is very important to their clinical outcomes and keeping those stents nice and clean and open. So then lastly, just a slide here on pharmacodynamic interactions, where previously we were talking about the kinetic interactions. So CNS depressants like alcohol, opioids, benzodiazepines, tricyclic antidepressants can cause additive cognitive and psychomotor impairment. So again, caution with our patients if they're using THC or CBD products as well as CNS depressants. And then with some pathomimetics, so we have amphetamines, cocaine, noradrenergic, and anticholinergic agents. With THC, there's the potential for additive tachycardia, hypertension, and fluid retention. And then with CBD, no interactions noted thus far. Whew, all right, summary. Ensure your patients have accurate medication lists, including herbal supplements. So again, I really encourage you guys to always kind of have that as part of your conversation when talking with patients, is to ask about herbal supplements. Assess for clinically significant drug interactions. The two that have true clinical drug interactions in this presentation are Goldenseal and St. Johns Wort. So if you at least remember those two and say, oh, Paige mentioned those, I'm supposed to think about something, and go through their medication list or consult me, whichever. Those are the two that have the highest risk for drug interactions. And then lastly, I always just really encourage open dialogue with patients on their use of THC and CBD products. Again, just to help look at those kinetic and pharmacodynamic interactions. It might be something where we're having a hard time controlling heart rate or blood pressure, and really it's an interaction we're seeing because of their use with THC and CBD products, or maybe they're really bruising and bleeding a lot, and we don't know that they're using, recreational marijuana or medicinal marijuana, and that might be, something that we might clinically change with their medications, if they're not willing to stop to help keep the patient safe. So that is what I had for you guys. Here is a long list of references. As you can imagine, a lot of this are single case series or, smaller references. And so at that time, I'll open it up for questions. I'm happy to answer questions via email or Epic. This is the horse Stella. We were just down in Arizona. She's with a trainer. She's known to be a little spicy, so she's in boot camp for the winter. Yes. Oh.
Paige, interesting presentation. I think that just like a pharmacologic presentation on all these supplements, there could be a psychological presentation on these supplements. I find in my clinical practice that the multiple supplement users tend to run in the same crowd as the anti-statin users, the anti-vaxxers, and the multiple allergies crowd.
Mm-hmm.
I've also noted that over the years that tends to be the next trendy supplement, and I've been through many series of the trendy ones. The ones that I see right now are that weren't mentioned. Some were would be apple cider vinegar,
Mm-hmm.
turmeric,
Mm-hmm.
and melatonin. It's interesting with melatonin. It's the one example I can think of where I know that we can prescribe it in the hospital. That's
Mm-hmm.
used now as a sleeper.
Yep.
So anyway, those are the three that I
Yeah. Truthfully, I'd have to look into interactions with apple cider vinegar. I know turmeric is kind of like a natural NSAID, so with that, if you have patients on anticoagulants or antiplatelets or any kidney concerns, those would be things to keep in mind. And what was your last one? Melatonin, yeah. So really the best data with melatonin is on helping to regulate your sleep and wake cycle. So the data was actually with pilots originally that, are flying at night and then sleeping during the day or vice versa. And so there actually is some fairly good data for the use of melatonin and helping in that sense. I will say I know that can also affect warfarin. That's one that with our LVAD patients that are on warfarin, they leave the hospital on melatonin, it's kind of one of those I say, either use it or you don't use it. It's not like, oh, I can't sleep tonight, so I'll take a melatonin, because A, it's not going to be as effective that way as if you take it daily. And then also that's where you can see fluctuations in INRs as well. So it's always something. But I would kind of agree with what you say. You know, there's some patients that just really draw towards the natural, which I think is okay. It's as long as we can have that open dialogue and you know, explain to them the risks versus benefits of their medications and their supplements. You know, I think most of the time the patients will come to the same conclusion that you're recommending. So.
We just have one online question, and that question is, should we be condoning the use of any non-FDA approved products, given that the benefits are often unclear and there are risks?
That's a great question. Yeah, I think, you know, again, I always think back to the oath of the pharmacist, and probably similar to what you guys take with as a physician. You know, first, do no harm. So that's whenever a patient asks me about an herbal supplement and if they can take it, I first look at, you know, what is currently going on with that patient, what medications are they on, and what is the data truly behind, you know, whatever herbal supplement they want to take. And so that's kind of usually the approach that I take. I don't know that I've really ever recommended you should take supplement X to improve your ejection fraction or, you know, things of that nature, because again, we don't really have much data. And it's hard because, as you guys are very well aware, where we get our clinical data is through the use of new medications and brand name medications. And so these herbal supplements aren't studied because the supplement companies aren't making any money. And so again, it's a sticky question, I guess.
Is there good data that like Coenzyme Q10 helps with statin myopathy at all, or is it just all kind of anecdote?
I didn't look into it a ton. I know from my experience kind of with our patients, I like to think it's a little bit more placebo, truthfully. But if it works and it gets them staying on a statin, I think the risk versus benefit, the side effects of Coenzyme Q10 are so low. Drug interactions, from what we know, are likely minimal in terms of clinically significant. And then if it potentially keeps them on their statin to help, you know, with their cardiovascular risk reduction, then yeah.
Great talk, Paige. Are you familiar whether, do you know whether our APPs, different services, is the AKN resources, are they used broadly or are they aware of it? What's are you familiar with the topic in general?
In terms of if the APPs use, like...
Yes, all those resources, because
yeah.
I mean, that seems like a very, very helpful resource.
Yeah.
Everything you said was quite amazing for me. It's, you know, for majority of us, I think
yeah.
Maybe not, but there's obviously a lot of our patients are on multiple supplements.
Mm-hmm.
They come to surgery, and you know, whenever they ask me a question, it's really way above my
yes.
clinical knowledge right now. So, do you know if that's something that is enough kind of advertised or
yeah, you know,
communicated with APPs, because they are our, you know, true. They protect our patients and us from
yeah.
missing something.
So I'm not sure how often they're utilizing like natural medicines or the AKN. That's kind of why I wanted to put that in this presentation so that it could be referenced back. Kind of like I mentioned, if someone ever says, oh, it's on the AKN, I kind of chuckle and I'm like, oh boy, hope I could find it. And so it actually is pretty easy if you know how to get to Micromedics through the AKN. It's only a couple more clicks through there. So I mean, it's something I'm not sure if like these slide decks are emailed out or, you know, how the best way to kind of advertise this resource would be. But
do you hear a lot from our APPs? Do you hear a lot of questions? Do they reach out a lot or not?
I know I hear a fair amount from our heart failure group in terms of herbal supplement use, because usually it's the nurse in basking the doctor, and then the doctor pings me and says, Paige, help. and that's totally fine. That's exactly what I'm here for.
You would put together like 2-3 slides with those references that
Yeah.
just kind of isolate them and send it to me, and I will distribute it amongst
Yeah.
medical service.
Yeah, and if that's something you guys think, across,
Yeah.
the general cardiology, EP, all the groups.
Well, and your presentation is recorded too, so it's
Okay.
easy to access on the MHIF website.
Okay.
So that they can listen to it. And they also have a Friday conference where many times presentations like this would be ideal.
Okay. Is that still
And I'm sure there's many of them that are online today.
Excellent. All right.
Just a couple more online questions, if you're willing to answer just a couple
Yeah.
more. So the first question is, does topical CBD have the same potential for drug interactions?
That's a really good question. I would truthfully have to look into that, and I can kind of get back to you guys on that, but I don't want to say something that's not true, because I know that's a huge thing now. I mean, there's CBD shampoos, there's CBD body wash, there's all sorts of topical CBDs.
Yes, it depends how much you apply and
Yeah.
how much of your
I
body
can
you cover.
extrapolate some potential answers, but again, I don't want to say anything that's not true. So if you know who asked the question, I can always look into it and get back to them.
Sounds good.
Yes.
The last question would be, which is better to use, natural medicines versus the NIH Alternative Medicine and Supplement Database?
So I think they're both really good references. I kind of gravitate towards natural medicines just because of my familiarity with it and ease of getting to it through the AKN. But the NIH database is also a good resource to use as well. So if you wanted to be very thorough, you could double check both. Yeah, those I would say are probably the two most commonly used.
Excellent. Well, thank you very much.
Yeah.